Hello. Thanks to Dr. Blum, he's inspired me to come here and present this. My background is actually, I was an upper cervical chiropractic, worked with Dr. Grostic for many years from 88 to 95 when he passed, and just recently in the past 13 years I've been involved with Network Spinal Analysis and working in some of their research. And this is a study, it's an inter-reliability of the Achilles heel tension test, or heel tension. We did this at a seminar, a network seminar. And just some background, of course, D.D. Palmer, life is an expression of tone. And tone is expressed in function by normal elasticity, strength, and excitability. The cause of disease is any variation in tone. And I'm not sure if he actually was talking about tension in the brain, the spinal cord, or the nerves, but he did set the tone. Desjarnais, I believe, or Desjarnais, I'm not sure how to say that. Desjarnais. He, as far as I know, was the first one to introduce heel tension and the idea of dural tension or spinal cord tension in with chiropractic. And he said heel tension is the common denominator of dural faults. Dural faults produce motor neurofailure, and this failure may be a spinal reflex or it may involve the upper motor neuron cells of Betz. Any involvement of the dural membrane, intra or extracranial, will always be associated with abnormal heel tension. And this heel tension is tendon and ligament tension, as are all neuron abnormalities. Many neurological signs are evolved from this particular area of the human body. Alf Brieg is a neurosurgeon, and his study in histodynamics, lots of work, and his model of the adverse mechanical cord tension. And he regards the peripheral, central, and autonomic components of the nervous system as a continuum with two intimately related components, a connective tissue component and the neural tissue component. Ingber and biotensegrity relates it even more, and he's more recent. The spine and all of its surrounding soft tissues, including the meningeal and nervous tissues, form a linked closed system where change in tension and distortion influence the entire functional unit and change the degree of tension in the spinal cord, thereby modulating tonal frequency in the central nervous system. And Donald Epstein has put all these people together into his model of which he calls model spinal and neural integrity, relating the maintenance and improvement of spinal integrity of an individual to the interaction of communicating subsystems. Oh. I'm not so good at these PowerPoints, but there you go. So spinal and neural integrity is defined as that state in which the physical components and physiological processes of the spine function are unimpaired, including the body's ability to develop new strategies to maintain an appropriate flow of energy through its tissues. That's as defined by Donald Epstein. And these are his models. He actually uses Panjabi's system, passive, active, and neural subsystem, but he also has the emotional subsystem linking into that and affecting all three. I'll do this fast because there's more to go. But the adverse mechanical cord tension, in his beginning models, he had the facilitated subluxation, which was caused from neural tension, and then the structural, which is more structural, a bone out of place affecting the nerve. And of course, the stress physiology affecting the posture. So why should we do reliability studies? What's the importance of that? With a scale where we're saying it's a mild to moderate to severe, it's very important. And we're documenting the potential of a scale to produce stable results within and across assessors. So the test-retest reliability is a prerequisite for scales that are to be used in a follow-up situation, such as with chiropractic care, and help to document its objectivity. We call this guy Meningeal Mic. So that's an example of somebody with extreme spinal cord tension. Looks a little angry. So in this particular study, it was actually a pilot study, and we had 21 volunteers from the conference itself who were participating in the conference, 17 women and 4 men, 3 different examiners. They were all network practitioners, advanced certification, and actually instructors in the program. They all had over 20 years experience individually. Each subject was examined at 2 separate times, and when they came in the room, we would give them a number. We didn't call their name. Or when they were examined, they were instructed to lay prone on an adjusting table with their shoes off, their legs and ankles hanging over the edge of the table. And then each practitioner was paired with somebody to collect the data, and there were signs, hand signs that were devised so that nothing was spoken, so the different examiners did not know what the findings were of the other examiners. This is me doing a heel tension test. So that's what it looks like. I believe SOT, there's a lot of different factors, and there's some different factors in NSA. All we measured the reliability was for the flexion, going from plantar flexion into dorsiflexion. So in this test, as used in the study, we take the eversion out so that the Achilles tendon is lined up with the leg. So the eversion is taken out, and then you go into full plantar flexion, and then all the way down into dorsiflexion, which this test is used in chiropractic, in SOT, in network, TRT, but also it's used in orthopedics. And it was interesting in my research of all the different articles, one in spinal surgery, they'll actually test clonus, which is actually forceful dorsiflexion, and that the presence or absence of clonus is more predictive of spinal cord injury than an actual like SEP, or which I thought was really interesting. Side note. So the results, the heel tension data was scaled with 5 levels, mild to severe, 1 being mild, 5 severe, and it was treated as a scale variable. I saw in the notes that Ed Owens actually did all the statistics for me, but I don't think that his name was in there. But he used the interclass correlation, which is appropriate in this case for both intra and inter-examiner reliability. So we compared each doctor's findings on round 1 to the same doctor's measure on round 2 to assess intra-examiner reliability. And then the findings on the left and the right side were dealt with separately. And these are the results. With interclass coefficients, above a 0.8 is very strong. So it's actually very strong reliability on the intra-examiner reliability. And it's actually a little better on the right heel than the left heel, which is just a little bit of interest. And examiner 1 was much better than the other 2. And then this is the inter-examiner reliability, which often is less. I think it's almost always less than the intra. And in here, we're having moderate reliability. So ICCs of 0.58, 0.64. So in this study, the intra and inter-examiner reliability of the heel tension measure used by practitioners was substantial, and it appears that this is a reliable objective finding. So what next? Yes. 1 minute. So now we look at validity. Is heel tension actually measuring tension in the spinal cord and the brain? And there's actually several different studies that already are pointing to the validation. Reed and Brieg back in the 60s and 70s did that with cadavers and showed that with, I think it was with straight leg raiser and dorsiflexion, actually you get movement of the nerves into the spinal cord. And then more recently, Boyd and Carroll. Actually in 1992, Wall, this was a big one back then, actually when you have tension in or stretch in the tissue, you change the conduction of the nerve tissue. And there was a study in 1991 that I actually was involved with where we looked at SEPs and adjustments. Upper cervical was what we were doing in that study, but increased conduction. So there's lots of different things that we can relate to it, but I would love to see heel tension and correlate it to maybe an SCP, or right now they're using magnetic resonance elastography. I think I said that right, but just I think it was last year, they're looking at tension in the nerve tissue in the brain. And in people with MS was the study I looked at, of course, have increased tension in the neural tissues. Yeah. And that's pretty much it. And it's such an honor to be here. Thank you.